My, I guess, journey in terms of MIS and wanting to get into doing the MTPs prior to this system, I was absolutely bought into the MIS techniques and the MIS philosophies and concepts. My hesitation, if you will, was largely the construct. We all know from biomechanical studies that the superior construct is going to be that dorsal plate with a compression screw. And so trying to achieve the same thing with the crossing screws, two crossing screws, I absolutely think that you're able to achieve fusion, and we have good studies that show that, but I felt less confident in being able to progress them as quickly as what I would like with the plate. And so I dabbled a little bit in terms of even mini open or small plates or even staple constructs, but still through an open technique to try to make it as MIS as I could. And then once Optima became available and we're able to really minimize the incisions, we've kind of progressed pretty much to doing it all that way. So we still get that compression screw with the superior biomechanic stability, but still with the minimal approach and minimal soft tissue disruption. From a patient perspective, I think that the shift to MIS versus open has been dramatic. Admittedly, I've not changed my post-op protocol dramatically, so I think that that introduces a lot of different variables that may have changed the experience. So my post-op has stayed the same. I still splint people and keep them non-weight bearing for 2 weeks. The progression in terms of their comfort has been dramatic. I mean, these people have minimal pain. Even at that first post-op visit, they're taking very little pain medications post-operatively. Their soft tissues seem less angry at that initial visit. And then on the back end of this, these people are able to transition out of whatever post-op shoe or immobilization you're using into a standard sneaker or tennis shoe much faster, just because their soft tissues are less swollen, they're less irritated. So I think both in the early post-op pain as well as their transition post-operatively into normal sneakers and normal activity, it's been a huge win all around for the patient. I think describing my process in terms of including the OptimalMTP system for MTP fusions, the first couple of cases, admittedly, I chose patients as well as deformities that were probably a more straightforward approach that wasn't going to require a huge reduction, and it wasn't a revision case. And in that sense, I was also hyper-vigilant in terms of being really confident in myself and knowing that I had fully prepped the joint, because I'm not able to actually see the articular surface. And so even at that point, we were doing accessory portals to try to make sure that I was getting the burr all the way around the joint. And so in doing that, sure, there was somewhat of a learning curve and somewhat of a, extension of the process. But now that we've gotten this down to somewhat of an efficient process and a stepwise approach, the efficiency of this system outweighs what I was doing as an open approach in terms of timing, in terms of steps, in terms of even fluoroscopy or extra assistance. And so I think that the learning curve happens quickly, and you kind of learn those quick downfalls early on, and then you're able to proceed pretty quickly.